clinical trial, because in 2010 there was nothing FDA approved to treat this particular patient population. There's nothing they could do. Everything changed in 2011 when we started to have immunotherapy, albeit not the best immunotherapy drug come onto market, but that really changed everything. What's also interesting is that in 2018, we now have something like 11 or 15 FDA-approved indications to treat melanoma, so it's been fantastic, a complete revolution in the way this particular type of cancer is treated based on genomics. And the Nobel Prize in Medicine and Physiology this year went to the initial discoverers of immunotherapy, which was first applied to melanoma. And the reasons for this are because it's long been known that with patients with skin cancer, they would present with lesions, and then at follow-up appointments, some of those patients, the lesions would be gone, right? They'd come back, and the skin cancers were no longer there. You also had pathology looking at skin cancer lesions for a long time, saying that there is complete infiltration of T cells and B cells, all kinds of immune cells in these tumors. Why aren't they fighting off the tumor? Why are the immune cells at the correct site? They're infiltrated, but they're no longer active. And so answering these types of questions is what led to a revolution in this type of therapy. In addition, what I have on this first slide are the drugs that really have the pharmacogenomic applications. And so it wasn't until the Human Genome Project came along that at first it really didn't seem to make an impact in a lot of cancers, the exception being melanoma. So with more than half of all melanomas, when they would look at the genetic sequencing, they would see this same mutation in BRAF, which is a protein kinase in a very, very prominent signaling pathway in the cells. And this mutation just happened to be in the active site of this particular protein, meaning that it was constantly on in patients with this mutation, and it showed up in more than 50% of melanomas. And so it was that kind of information that we got from genetics, which really helped elucidate the Achilles heel for melanoma and to help us get a good idea of how to go after this disease, because without knowing about the immune system and without knowing about genetics and BRAF, really wouldn't have made the progress that we have. And so you've seen this before, where I'm showing all different types of skin cancer. We have the non-malignant types, the basal cell carcinoma, the squamous cell carcinomas, and these are far, far more common in society in the United States. Melanoma is not as common, but this year we're up to over 91,000 patients, males and females, that will be diagnosed every year. This is striking to me because it used to be 50,000, and then we were up to 70,000 and 77,000. And then between last year and this year, it jumped. So this number has grown exponentially, it seems like, not quite. But every year we have more and more people in the United States diagnosed with melanoma, which is problematic because this is the most aggressive type of skin cancer. And this is the type of skin cancer that, with the diagnosis of melanoma, we're not quite sure what the outcome is going to be. We know with basal cell and squamous cell carcinoma, these aren't highly malignant. We know we're going to remove them. We know the patient's going to go on to survive. But melanoma, it's a little different. The outcome is going to depend on a lot of different factors. Ulceration, vertical growth rate, radial growth rate, so the depth of the lesion, a lot of different factors, whether or not it's metastasized, are going to come into play. Melanoma is a cancer involving the melanocyte cells. These are the cells that produce melanin, which control skin cancer. So people of color have a lot of melanin. Their skin is very pigmented. People that lack color may have moles or freckles. Those are made up of melanocyte cells on their skin. But when these cells become cancerous, this is the most dangerous type of skin cancer, and it's the leading cause of death from skin disease. Early stage melanoma can be removed. Late stage or metastatic melanoma has a very poor progress. Now again, that's gotten a lot better over the years, and now we're able to treat these patients, and they can really go on to live many, many more years at a good quality of life versus what they were able to previously. These cells are really aggressive for one reason. It's the basic biological nature of a melanocyte. So what you see here on this graph is that this big green cell, this is the melanocyte. What it's designed to do is to protect the other skin cells. So when other skin cells are hit with ultraviolet radiation, they could die. What the melanocyte does is then secrete melanin to these other cells, right? It produces these from the Golgi and export these, and the other cells take them up. So now the other cells have a little bit of pigment, a little bit of color. You might also refer to this as like the tanning effect. And the misnomer that that's a healthy glow. It's not a healthy glow. What that means is that there has been ultraviolet radiation damage to that skin in that area, and now the melanosome has become active in this cell type, in the melanocyte, and so it's trying to protect the other cells. This is interesting because, again, a lot of cells exposed to ultraviolet radiation would simply die, but this is a very aggressive cell. It's more like a protector or a fiber type of cell. So when it becomes cancerous, obviously due to its aggressive nature, it can be very, very ugly, very nasty. This is looking at the objective response rates to those therapies in melanoma that have a companion diagnostic assay versus those therapies that are just sort of randomly applied, or not randomly applied, but applied without a companion diagnostic. And so I just want to highlight the differences. And so here we have drugs for melanoma that are looking for mutations in BRAF, and the response rates of these drugs are about 50%. Not 100%, but decent, versus those drugs that are applied without a companion diagnostic, so for melanoma. And these are immunotherapy, and the response rate for these is there, but it's not as high, suggesting that when we apply pharmacogenomic principles, when we understand why
Dr. Murph, we can't hear you. Savannah, you cut out.
Same with Albany.
Okay, well, I've got two options here.
We just heard you say that, though.
You did? Excellent. Okay. Oh, is it working? Oh, it's back. Okay. I was just going to sit down and give the rest of the lecture. Okay, for all of a sudden the mic cut out, but I was going to try to change the battery, but it's green. So I didn't think that was the problem, but I was going to do it anyways. Okay, so that not being the problem. All right, where was I?
Response rate.
Let her know.
All right, moving on. Okay. So what this slide is looking at the different types of subgroups in melanoma. So up here at the very top, here is the identification of genomic subtypes. And for most of our purposes, for the rest of today's lecture, we are interested in that genetic subtype whereby more than half of melanomas will have a very specific mutation in BRAF. These patients oftentimes are younger, they may have amplifications, but when we look at the mutation subtypes, we see that this is BRAF. Most common is the valine 600 mutation. So that valine amino acid at that site is where the mutation is. It can also be lysine at 601, but again, this is the more prominent mutation. So in this lecture, you're going to see V600E, where the valine is substituted for a glutamic acid. You may also see V600K. The V600K is not as common as the glutamic acid, so K is lysine, but it means that the valine has been substituted for glutamic acid, or the valine has been substituted for lysine. Glutamic acid is far more common, but the outcome is the same in that that particular mutation is causing that protein, BRAF, to constantly be signaling on, which continuously drives the growth and the proliferation of those cells that have that genetic mutation. And again, it wasn't until sequencing was possible that we were able to sequence all these melanomas and identify that more than half of these things had that specific mutation. The rest of what's on this slide is not important for testing purposes because we don't have drugs that hit these other mutations. But we do know that there are other genomic mutations that exist in melanoma. We know we have other subtypes. We would love to go after those subtypes. And that's where a lot of research is focused, is looking at those other subtypes and trying to come up with drugs that target those specific things so that we can see that revolution that we've seen with BRAF inhibitors. And so this falls under a hotspot, which is class 1, clinically actionable. So if we have patients that have these BRAF mutations, then we are able to administer BRAF inhibitors. But what you will hear in the story today is that BRAF inhibitors weren't enough. We also have to go in with MEK inhibitors. So if patients have a mutation in BRAF, they will not only receive BRAF inhibitors, but they will also receive MEK inhibitors in combination. What was happening was that you would inhibit BRAF. That would work for a few months, but very, very, very quickly, resistance was happening. The cell would simply rewire itself and bypass that. And that was learned from the clinic. Didn't show up in the lab, that showed up in the clinic. And so the clinic went back to the lab and said, okay, this isn't enough. It's working for a little bit, but we need something else. So then the researchers and pharmaceutical companies came up with the combination to say, we will inhibit both of these steps so that it can't just simply rewire itself that quickly. Now, we do see resistance evolve, but not as quickly and aggressively as it used to. So here's the formulary of therapeutics that we can use against malignant melanoma. So we have basically two areas. We have immunotherapy, and we also have these targeted inhibitors, which I've been talking about. When it says for the MAP kinase pathway, that's the signaling pathway that BRAF is involved in. BRAF is like step 2 in that pathway. Very, very popular signaling pathway in science. And so we have a spectrum of inhibitors. We have those that are BRAF inhibitors. Why do we have 3? Because we have 3 different drug companies that jumped into this market. We have our first in class, and our second in class, and our third. So we have our initial drug, and then we have the Me Too drugs. And then, so these are all BRAF inhibitors. And then we also have our MEK inhibitors, which are these other 3. And these MEK inhibitors were what the clinic figured out that we needed in order to make this approach work better. Work in general and work better. Now, they did a lot of clinical trials to see, can you do BRAF inhibitors, and then when they become resistant, can then you do a MEK inhibitor as monotherapy, and that was a clinical disaster. What they found is that using the combination of both up front is a far better approach. And so here's what this looks like. So vemurafenib, also known as Zelboraf, was the first FDA-approved BRAF inhibitor in 2011. Again, it wasn't approved with a MEK inhibitor. The company is now Genentech. Genentech acquired the company Plexicon. And vemurafenib stands for the V to E mutated BRAF. So V to E mutated BRAF. So if you remember the name, you should remember the mechanism of action very easily, because that's why it's VE, vemurafenib. And this is a BRAF inhibitor. Now, its MEK inhibitor did not come until 2015 because, again, the clinical trials had to work their way through the clinic to understand you need another drug in combination with this. But GlaxoSmithKline jumped into the market, and so they have their own BRAF inhibitor, dabrafenib, for BRAF. And when this was approved, it was approved in combination with their MEK inhibitor, trametinib, or Mekinist. And then just this summer, Array Biopharma came out with their response to this market, and that's with Braftovi, encorafenib, or Mektovi, the MEK inhibitor, benimetinib. And so this is the signaling pathway. So it's going to start with the receptor at the cell surface, which is going to signal through RAF. So I usually call this step 1. RAF is step 2, because this signal then goes through RAF, which, if I have it yellow here, it's constantly activated. in 50% of melanomas. And so this is always on and it's always signaling, so it doesn't even really need this signal, right? It doesn't care if the receptor is activated or not, because it's turned on by this genetic mutation. So this genetic mutation is a somatic mutation, right? It's not germline. So the theory is that it does develop from ultraviolet radiation, and that through the ultraviolet radiation exposure, the DNA damage, it hits BRAF, BRAF then becomes activated, and then you have the formation of melanoma. That's the hypothesis anyways. MEK is step 3. And what they learned is that if you took out BRAF, even though this didn't need to be signaling, it would start to signal, and it would just bypass this step. Now, it would do that eventually, right? That didn't happen overnight, but eventually that's what the tumor would do. It would create more somatic mutations. And so then they had to come up with an approach to have like a 1-2 punch. So this is the first punch, and then this is the second punch. And that lasts a lot longer and has better therapeutic outcomes and better response rates. So if you're a visual learner, or if you like visuals like I do, this slide is for you. So 50% of melanomas harbor a somatic point mutation in BRAF, which creates this self-activated BRAF. So here's the mutant, and here I have the V to 600E, or position in the DNA sequence 1799. It's a thymine changed to an adenine. That is where this mutation is. So if that happens from ultraviolet radiation, then we have a mutant protein that is always on, always signaling. It doesn't care what the receptor is doing. It's of no consequence. BRAF inhibitors, such as either vemurafenib, encorafenib, or dabrafenib, will inhibit BRAF. So it comes in, binds to BRAF, no more signaling, tumor death. These are the newest drugs, so Braftovi and Mektovi. And what I have here are the highlights of the prescribing information. So the approvals for these happened in 2018, so it was around late this summer. These were FDA approved. And in the dosage and administration, it says you have to confirm the presence of BRAF, either V to 600E mutation, so valine 600 glutamic acid or valine 600 glycine in the tumor specimens prior to the initiation of Braftovi. Okay, so this is absolutely has to be done in order to dispense that medication. These are oral too. And same thing with their MEK inhibitor. So this is a MEK inhibitor, but you also have to confirm the presence of BRAF. So you're basically confirming the presence of a mutation in a different protein to give the MEK inhibitor. But the reason why is due to the clinical use of a monotherapy BRAF inhibitor, and it wasn't sufficient for the clinic. But the two of these together work a lot better in shutting down this pathway for longer. Better response, better quality of life, better progression-free survival. However, what we also learned when we first had just the BRAF inhibitor was that the genetics were a lot more complicated than what we initially expected. So we would shut down BRAF, and eventually we would get this bypassed signal, and MAP kinase would be activated again. We also didn't realize that the protein RAS, which is first in this sequence, some of these, about 25% of these patients, were also harboring a mutation in RAS, which wasn't apparent until you shut down BRAF, and then this thing was able to then become activated. And due to the mutation in RAS, we were seeing the manifestation and the appearance of these keratocarcinomas, or squamous cell carcinomas. So these are these dome-like appearance shapes on the skin. And in 25% of patients, once they would start a BRAF inhibitor, these things would pop up all over. And again, it took a while to figure out what's going on. So that's another reason to give the MEK inhibitor, because when you administer these two drugs together, then you don't have this paradoxical appearance of squamous cell carcinomas all over the skin. So now let's talk about the companion diagnostics. So you saw in the drug label that patients have to be tested to make sure they have the mutation. And you also know that the FDA approves these diagnostic tests to go with the drugs. So vemurafenib has the Cobias 4800 BRAF V600 mutation test. This is for formalin-fixed paraffin-embedded human tissues, and they are looking for a positive test in detecting this mutation. And here they're saying it represents 85% of all BRAF mutations, which is probably about right, meaning that if BRAF is going to have a mutation, most of the time, this is where it's going to be. Not 100% of the time, but most of the time. And then dabrafenib, the second drug, so this is the Me Too drug for vemurafenib, which was first in class. So dabrafenib has a different diagnostic device. So this diagnostic device is intended for the qualitative detection of BRAF V600E, V600K in DNA samples extracted from formalin-fixed paraffin-embedded human melanoma tissues. So just different product to do the diagnosis for that particular drug. Now, encorafenib, from what I can tell, doesn't have a very specific companion diagnostic. It could be either or. So far from what I can tell, again, it just hit the market, but it doesn't seem like it matters which test you're going to use. But these drugs have just a little bit more specific information in their drug labeling. And this is what these drugs look like, alone or in combination. So again, they wanted to improve the response rate for progression-free survival. So here's the vemurafenib in combination with cobimetinib. So this is a BRAF and a MEK inhibitor put together. And when you put these together, you see a progression-free survival of 9 months versus this is vemurafenib, so the BRAF inhibitor with placebo, so 6.2 months. So longer progression-free survival, so there is an improvement and evidence of a benefit when you're using these in combination. And here is the overall survival, which again is, from a patient standpoint, I think really the only thing that we should care about. And significant p-value in looking at the combination versus the drug with placebo. Toxic events were also observed at a lower frequency in the combination group, and specifically those squamous cell carcinomas. So here is what vemurafenib treatment looks like before and after. So in A, you see a 38-year-old man with melanoma just all over his chest and back. This was a BRAF positive patient. And then B is what it looks like after only 15 weeks of the drug. He looks vibrant, he looks healthy again, but unfortunately, this is after 23 weeks of therapy. This is C. And what you're looking at here is that these tumors, like pick a point, this is the same tumor that was here. So the tumors are coming back, and they're coming back in the same exact spot they were previously, meaning that we haven't eradicated the disease, but the BRAF inhibitors have shrunk these tumors sufficiently so that after 15 weeks on the drug, he looks like he is in complete and total remission. His quality of life is back to where it should be. So for that period of time, it's that miracle drug. It's that imatinib, that Gleevec story. But again, we have this remaining issue of drug resistance. You can see from these lines that you're extending that out with the combination of these drugs. Fewer side effects, longer time until these patients are going to hit resistance, but resistance still remains a problem. And this was baseline PET scan, and this is 15 days, so same patient after that PET scan. And again, PET scans work really well when we have those very active, aggressive type tumors like something in melanoma, and they're perfect for clinical trials to try to gauge, is this drug working or not? And for this clinical trial, this was just really, really exciting at the time. Here is dabrafenib plus trametinib. This is the combination, and this is overall survival, so these are the other drugs. So I'm just showing you, this is the Me Too drug in combination with its Me Too drug, the BRAF inhibitor and the MEK inhibitor. And it does better against placebo, and overall survival, it's statistically significant. And again, we're hitting both of these targets as opposed to just the one where the mutation is. And now we're going to talk a little bit about the immunotherapy. So that's all I want to say about the targeted BRAF and MEK inhibitors. So the role of the immune system we always knew was a really big deal in melanoma. We could see that some lesions that appeared over time, they would simply fade away. At least 10% of primary tumors undergo spontaneous regression. Partial regression is more common. 50% of primary melanomas removed by surgery have histologically identifiable regions where regression is actually occurring in real time in the tumor. And we would always see an infiltration of immune cells in tumors. So for example, here is a slide from my own work And what you're looking at here is these very, very large hepatocytes. So this is in the liver, right? So all of these giant cells are hepatocytes. All of these little tiny cells that you see in this huge region, these are T cells. So this is the immune system. And you can see the immune system is completely surrounding these cells. So again, we would always see this with melanoma, and we would say, why aren't these working? What has the immune system done, or what has the melanoma done to shut off the immune system so it's no longer responsive and it's no longer working? And again, working that out is what led to the Nobel Prize being awarded this year to those scientists. And so really it was a matter of communication between the two cell types. So now we have melanoma immunotherapy. We have the first in class, which was ipilimumab. Ipilimumab targets the CTLA-4 immune system inhibitor. And then came along pembrolizumab, which is a superior drug to that. It's got a lot of different approvals, so it's not just melanoma. Once these things started working, clinical trials in a lot of different types of cancers started to arise, and so their approval is far, far more widespread than what was initially anticipated. And nivolumab, which is an even newer PD-1 immune checkpoint inhibitor, and this is the superior drug. So if I was to compare all of these three, I would definitely say they work in this order. Nivolumab, a little bit better than pembrolizumab, far better than ipilimumab. So for not just stage 4, but now we're also seeing approvals where these can be used at much, much earlier stages for lots of different types of cancer. So this is really changing. But when you first run a clinical trial, you're likely to get the sickest patients that have been on multiple therapeutic regimens. You're not likely to get those naive patients or those early stage patients. But what they see is that immunotherapy is perfectly appropriate. You can also use it in combination with the BRAF and MEK inhibitors. So you can use it after that therapy, you can use it with that therapy. So patients have a lot more options today than what they previously had before all of these things were approved. So let me just briefly mention the molecular mechanism of action. So this is for ipilimumab. Ipilimumab is going after CTLA-4. This is involved in the second step of co-stimulation and immune checkpoint to regulate whether or not the immune system is responsive. So initially, what happens is that the MHC, class 1 or class 2, will present molecules to immune cells. Immune cells, like the T cells, have receptors that recognize these molecules. So this is just basic immunology, so you probably remember this. But there is a second step in that process, and the second step involves a subsequent step of interaction where there is a receptor B7 in the cell that's expressing the antigen and CTLA-4 in the immune cell. And CTLA-4 is actually an inhibitory receptor. So all of these T cells are designed with an inhibitory receptor that can shut down their immune response. And at first I found this perplexing. I thought, well, why in the world would you want that? Well, obviously in cancer you don't want that, but if there is an immune response or some sort of inflammation in a patient that is beyond the point of helpful, maybe it's gone pathogenic, think about an allergic reaction to a bee sting or peanuts or something like that, that can actually kill the patient. And so this response was designed to shut that down. But cancer cells are hijacking it, not a shock. And so what was happening is that the immune response was dampened. So these two receptors would come together, and the second step would end immune response. And so now the tumor cell was available to proliferate. And so ipilimumab was a monoclonal antibody that would bind to the CTLA-4 receptor. And that would prevent the T cells from shutting down the immune system. So the immune system would stay stimulated, it would stay on in the presence of ipilimumab. Unfortunately, this was the first drug, so it was suggesting that this was possible and capable, but it wasn't a very good drug. So in the first clinical trials, there was like 1% of patients were having a complete response. A lot of them weren't having a response to this. So the idea was that the concept worked, but this is not the best receptor. So what happened is, here's an example of a patient with ipilimumab refractory melanoma, meaning he was on ipilimumab and it stopped working, which again is common with a lot of these drugs. And so he has this melanoma that's growing again. Then he went on a clinical trial for an anti-PD-1 antibody, and then after 3 weeks, now he's able to open his eye here, and his hair is growing back, and he's looking a lot better. So meaning you could fail one immunotherapy, and then you could go on to receive subsequent immunotherapy. And again, it was part of a clinical trial to show that this was possible. And so the clinical trial was a clinical trial for, I believe it was pembrolizumab at that time. And pembrolizumab has the same concept to make the immune system recognize the tumor again, but it does that through interaction with a different receptor on the T cells. And so here was, again, the ipilimumab mechanism of action, blocking CTLA-4. And here is the mechanism of action for nivolumab and pembrolizumab. So you also have these receptors. The receptor is PD-1 on the tumor cell and PD-1 on the T cell, PD-L1 on the tumor cell. And so this is another mechanism to shut off that interaction between them. And so what the PD-1 inhibitors do are that they bind to this receptor so that you can't shut it off. Right, so that you're trying to reach the point of tumor cell death. And this works fairly well. It's not a cure-all, but I'll show you some data to show that it works well. Now we have 3 of these drugs, these 3 approved in melanoma. We have 4 approved for non-small cell lung cancer. And so we're likely to continuously see more and more immunotherapy come into play in anti-cancer therapeutics. And so, for example, here's pembrolizumab against ipilimumab. So here's at baseline, we see this melanoma on the cheek. 90 days after pembrolizumab, we see a remarkable diminution of the tumor, and we also start to see the infiltration of CD8 positive T cells in the tumor site versus there weren't many there initially. I mean, there were a few, but there wasn't this robust response. And what you're looking at here is a waterfall plot. So a waterfall plot measures the minimum change from baseline, meaning before you start treatment or before you start a clinical trial, you measure the largest diameter of a tumor. And then that largest diameter of a tumor goes into the patient's chart, and then at follow-up, they're measuring that diameter to see whether or not it changes. Does it grow? Does it shrink? And by how much? And so the waterfall plot, you start at 100%, so each one of these lines is actually a patient. So there are lots of patients in here, and it helps show the data and how variable it can be depending on the person's response and the somatic mutations in that tumor. So for example, if we're at 0, here these patients really didn't have much of a change, 100% this tumor grew, but when you see this decline, these are all of the largest diameters of the tumor that shrunk, and there's a big population of 100%, meaning that those tumors completely went away in this particular clinical trial during this time point. The RECIST criteria is 30%, right? So the tumors have to hit that measurement in order for a drug to receive approval. 30% is the way they measure it. If you can't shrink, if your drug can't shrink a tumor by 30%, it won't receive approval. I know that we would like it to be 100% to receive approval, but the bar is not that high. I don't think most people know that, but that's the reality of it. Versus ipilimumab, where here is the 30% bar, and there are some patients that are in this group, but not nearly as much as pembrolizumab. So really with the waterfall plot, you're looking at what point does the water fall down, and it's right there for the 30% mark, and it's right here approximately for pembrolizumab. So pembrolizumab has much more activity in a larger percentage of patients versus ipilimumab. And so this is some of the data. There's tons and tons of data out there. This is just some of it to show, which is a superior drug when compared to each other. And we do have pharmacogenomics applied to PD-1 and PD-L1. So here we're looking at the interpretation of these. So there is now a little bit more rigorous genetics put into these and trying to identify patients for the treatment with drugs like pembrolizumab. Meaning, in this waterfall plot, not everybody responded to this, right? We would hope everybody would respond, but that's just simply not the case. So after these drugs were approved, then we kind of went backwards and said, okay, well, could there be a way to tell? And in fact, there is. There's this PD-L1 PharmDX product, and this is to aid in the identification of patients for pembrolizumab. Now, this is in non-small cell lung cancer specifically, but it can be applied to other types of cancer, where you're looking at the percent of tumor proportion score. So if we stain for PD-L1 and we want to know, well, how much of the tumor actually has that? If the tumor has less than 1%, well, then giving a drug that targets PD-1 is not going to be beneficial. Versus if the patient falls somewhere in the 1 to 49% range, or that tumor falls into the more than 50% range, you know that it's very likely that that drug is going to be very responsive to this type of tumor. So again, applying that pharmacogenomic principle and saying, this is a companion diagnostic to really identify which patients are going to work the best for this particular drug with this product. Here's another waterfall plot looking at nivolumab, which I said nivolumab is really a more powerful drug than all of them. So this was nivolumab and ipilimumab put together. So here is ipilimumab by itself. Again, the waterfall plot, we're looking at this, they have this dotted line at 30%. So we're looking at how many patients fall off this water plot. So this is a good thing, because these are the most responsive group. With nivolumab alone, we have a much, much greater proportion of those who are changing, and our median change is about 34%, which is good, versus the median change for ipilimumab is only about 6%. So in comparison, nivolumab has a much, much better record in that regards. Now, the next question was, if you put these two drugs together, because they have different targets, one's going for CTLA-4, the other one is going for PD-1, do they get better? And the answer is yes. We see a much greater proportion of responsive patients in this particular category, and the median change in the largest diameter of those lesions is almost 52%. So that is really good, and it's much better than nivolumab alone. The problem with doing this is that oncologists will say, you know, nivolumab by itself has really moderate adverse effects. Like, it's really a gentle drug to give. Patients, they do well on it, but when you combine two of these drugs together, everything is intensified. So there is a much, much greater risk for adverse effects, and you have to monitor patients a lot more closely, because ipilimumab just in itself has more adverse effects than a drug like nivolumab. And so there is risk to doing the combination. So it doesn't come just better without any additional risk. So these patients have to be monitored more closely. I think this is my last slide. So this is looking at the recurrence-free survival of nivolumab versus ipilimumab. And again, I said nivolumab is a superior drug because patients are doing a lot better, whether they are stage 3B, stage 3C, or if they are stage 4 with melanoma. Okay, so having finished that, now I will give you the password to your quiz for today. And please work by yourself, but feel free to use any reference, open note, open internet, open everything, but please work by yourself. And so the code is melanoma RX, and there are 6 questions, 5 of which are coming directly from this lecture, and the 6th one you're going to have to use CPIP or Pharmacogenomics to find your answer. And then that's all for today, so thank you for your attention.